All right, shift gears. We're going to come back to our own territory and talk about ED variation. When I first started doing improvement work in ERs, the difference between the least busy day and the very busiest day in most ERs was about 15%. That's the number I used to quote for people. Now I am seeing ERs where it's 40% or more. I'm working with an ER right now where so far since January, we've had a patient day with 149 patients, and we have had a patient day with 251. So just show of hands, how many of you feel like you're seeing that as well, that it's just like off the rails? And how do you staff for that kind of variation? Well, we're going to talk about some of the tricks that we know we can bring to bear. So basically, the name of the game now in an ER, when you build it, when you design it, when you operationalize it and manage it, is flex. How can I build flex into my system? And we're going to go through all the things. You can flex the flow model, the zones in the space. You can start assigning the waiting room. So even when they keep coming, you have processes in place for that extreme variation that day. You can flex your shifts. You can plan for something which I want you all to leave here and take to heart, called high flow. What will you do when the wheels are wobbling and coming off? We've talked many times about just cohorting the admissions, what that could look like. Behavioral health, we can at least take that off of our plate if we start to standardize and protocolize it so that, oh by golly, I've got a surge of patients and my volume's really high, but at least behavioral health is sort of managed. It's in hand. We've got the sort of processes for those patients. And then the newest iteration of a discharge lounge is a transition center, and I'm going to talk to you about that and how it applies to the ER. So flex the flow model. This is the most basic flow model for the smallest EDs. But what we're seeing is sometimes you'll have a trigger when a certain amount of arrivals come in. Now we switch to a different flow model. Okay, and if anyone is interested, I have collected and I have a set of slides that are these very simple diagrams of every variation of a flow model that I've seen. And if anybody wants to see that, I'm very happy to share, because there's so many ways to do this. As you get up to a significant volume, you're going to be doing something like this, and that is flowing of the majority of patients through a physician in triage. So you can do this on demand, or this can be your basic model. Now, mind you, there can be tons of variation on this. For instance, let's say you're getting so busy that your physician in triage is getting just overwhelmed. Can you stop, huddle in real time, and say, okay, we're going to change the flow model. Now let's send all fast track patients to the fast track in minor care. Let's bypass the doc, send them to the APP or whatever staff is going to work that. So the idea that your flow model, you likely should have one flow model for business as usual and one for high flow. The variation in our arrivals is so great that we need to do something different. All right, then the next thing, and I want you to appreciate this. Your flow model, your space, and your staffing are all intertwined, aren't they? And when I work with an ED that's going to redesign its flow, I always make staffing be last. I have us design what the flow model looks like based on the data. Then how can we make that work in our physical space? Now we're going to go back and staff it up, because we want to do it, we want to design the best ED for that department. We don't want to, you can always get limited by what you think staffing is going to limit. So this is showing, and I think I mentioned this yesterday, this is an ER where they're using that space as a mid-track part of the day and as an admission holding unit at night. This is Eisenhower ED, one of my favorite EDs in Palm Desert. What you're seeing is, and there's a happy, that's actually one of the residents, he's smiling, we just opened up their mid-track, but why I want you to see this is because it's a very, very cool way they've done this. Those rooms are mid-track rooms. At a right angle, right in front of the doctor smiling, there's a row of rooms. It is a fast track, and it can flex, and they have some rooms that can be fast track or mid-track. So can you flex, so depending on what they need, they can use these rooms one way or the other. Anybody doing that, this is very slick operations when you respond in real time by changing how you're using your geography and how you're flowing your patients. Anybody doing that? Okay, this is where we're going to go. This is the future. This is how we have to run our ERs now, because a static ED just doesn't work anymore. We have too much variation. All right, this is showing you this department. They use that little space, and behind the little curtains, this part of their waiting room, by the way, they are using it as a way to see patients in kind of almost a pit. And patients can go back to that little waiting area with the mishmash of chairs, and that can be a results waiting room for the mid-track kind of patients. Amy's going to be upset that I'm showing the slide. This is Lancaster General Hospital. I think this was such a bad idea. This is the waiting room. During COVID, there's plexiglass around every single chair, and oh my gosh, there's 82 of them, my friends. Oh my gosh, but as you heard, they are doing something different in part of their waiting room. So this is no longer their world, but that's how it was. Someone had that great idea. What do y'all think? You're gonna go home and build this, right? Yeah, I want one. Then I showed you yesterday, smaller ED using a hallway to be a physician and triage process. Now, this is VCU. They have a fast track that is staffed just by APPs. Most of the time, it's just moving and grooving. Remember, we talked about fluidity. We want rooms to keep moving. A patient only owns a treatment space as long as they need it. Then they may be in a waiting space. This is the hallway adjacent to their fast track. And what they've done is they've put some chairs, they've cordoned it off, they put a sign, and now it is their results waiting room for their fast track. They don't need it every day. But when it's getting busy and they've still got patients they're waiting for a lab test, they're waiting for an x-ray result, whatever, and they still have more people that need to be roomed and to be seen in their fast track, they've created a results waiting room. So they're flexing their space. I described this to you yesterday. When you get your new dream ER, all of you, you're going to want a room that is one room, but with the curtain pulled across, it can hold 2 patients. And remember, don't forget, Epic has to match that, or Cerner, and change when you make it be your high flow state. All right, assigning the waiting room, the Sacramento care model. This was actually from a poster presented to us here several years ago that I thought I would remind you of. So Centera Lee Hospital is in Norfolk, Virginia. This is a highly efficient ED, my friends. 35 beds, 70,000 visits. What do you think of that? Anybody know what we used to use? We thought that this was gospel. How many patient visits per room per year if you're designing ER? What did we used to say? 1,500 was the number. Do you remember seeing the data that Jim showed yesterday? Does that apply anymore? No, my friends. No, we're more down like 1,000. That's how much, because of boarding, because of complex medical conditions, and so forth. So this is astonishing to me that they can process that many patients in so few beds. They see almost 220 a day. They went to a leadership conference called IHI. Anybody heard of IHI? The Institute for Healthcare Improvement. If you don't go to our course, go to that course next year. You're going to learn a lot. It's usually in Orlando, usually in December. So they learned about this Kaiser Sacramento flow model and decided that they were going to implement it. It is a change package. There are many changes involved in this flow package, but I want to focus on a couple of them. The most important one is they decided when all of our spaces are full and people are coming in the waiting room, we are going to truly own the waiting room. Every patient in the waiting room will already be assigned to a provider and a team in the back. So they use something called the PASS system. It's patient assignment and sorting system. There are a lot of ways that you can do this. Patient assignment is a big deal in the ER. Who's going to actually take care of the patient, right? We need a provider, a room, and a nurse. And so they used this. It's actually a cloud-based tool that determines who should take the next patient. I've tried a couple of other things. I tried when I was at Intermountain Healthcare to have a system where a doctor or a nurse on a team in the back of the ED could say, hit me, like we're playing 21, right? We're in a casino playing 21. Hit me if I can take another patient. If I've got somebody that's going down the tubes, if I'm, for whatever reason, overwhelmed, I can put a note, I can't take anybody in my zone. What's wrong with that? I mean, it just doesn't work anymore. Every bed we need, unless you're going to say, they go to that bed, but maybe a different provider covers them. And I've seen teams do that, okay? But the hit me, don't hit me, let me tell you when I can take another patient, I don't recommend it, my friends. Does not work, does not work. But this assignment system prevents cherry picking. It means every patient is going to receive timely care. And I want to show you what their performance looked like. So they initially had some long wait times, but their change package got better over time. Have you ever seen this? Left without being seen of 0.4%. And you know why that is? Because the patients, their care was literally starting from the waiting room. And doctors and nurses were pulling the patient back. Oh, that's my next patient. Okay, Jill, move Mr. Johnson out. He can go home soon. And let me get that guy in the waiting room back. And that's really how it worked. So that's another way to flex. All right, flexing staffing. Anybody live near Dallas, Fort Worth? Anybody live near there? I've mentioned this ER, Texas Harris Health, probably one of the most efficient high-volume EDs in the country, 120,000+ visits a year. And Dr. Gesbray and his nurse, Dr. Gesbray, worked there for 40 years. He's passed. He was the ED director for 40 years. He had the nursing director at his side for 30 years. And together they did remarkable things. They were the most innovative department I've ever seen. They're the only high-volume ED that I know that could process patients without putting a physician in triage. They could process them efficiently. See the pale blue in the middle of the diagram? Those are 10 chutes. There are literally dental chairs, 10 of them, where they quickly came in and had a very quick triage, and then they were pulled to a room. Their ER is very acuity-based in terms of its zones. The pink was the critical care, most sick. The next one next to it, that purplish blue one, that was for major medical. Then they went to a mid-track, actually, in the orange area, and then to kind of a fast track. It was zoned, and the way that they staffed this was brilliant, I thought. A physician will start in the most sick area. By the way, this footprint is at least a football field in size. They will move back through the department. As a doc, I want to disposition my patients because otherwise I'm going to have somebody way over here and somebody way over here because I'm pulling back. Every couple of hours I'm moving back. And here's where the real flex is. The last part of the shift, the doctor is a procedure doctor. Just doing procedures, draining an abscess, putting in lines, doing all kinds of procedures, obviously not intubations, but any other procedure, nursemaid's elbow, whatever I'm going to do, anything that needs conscious sedation for sure, I'm doing procedures. Their doctors arrive, every shift arrives almost an hour later, they get sort of fresh meat, new doctors with energy ready to work. At that last 2 hours of being the procedure doc, if you're not needed, if the place is managed, you get to go home. So how about that? Is that one of the most, I wrote about this some years ago in ACEP Now. Anybody ever heard of this? I think this is very exciting and just really captures the imagination. So this is just explaining to you about how you go back in each zone. The other thing that they did, and I want to know if anybody else is doing this, they profiled physicians. And a physician could be a red doc, a green doc, or a yellow doc. And by the way, we know this about one another when we work, don't we? So when I used to go in and work the night shift at LDS Hospital, I would go in, and when they were hanging from the chandeliers, I'm like, what's going on? And then I would see, oh, Pete and Scott are working. Okay, now, I get it, right? Do y'all have your own Pete and Scott, right? Or maybe it's a Shari, I don't know. But in any case, They do not allow two red doctors to ever work right next to each other. What do you think of that? I wouldn't be threatened by it at all. Actually, I heard about it and thought, wow. And guess what they found is doctors, they would invest in those doctors to improve their efficiency, give them some efficiency training, send them to courses, whatnot. And they actually found doctors didn't stay in one place. Sometimes they were a red doctor, and all of a sudden, before you knew it, they were up to being a green doctor. So what do y'all think? Do you recoil against that, or what do you think? I think that's a very cool, in fact, I wish we could do it with the entire ED workforce, right? We know who some of our slower, sort of pokey workers are, both on the physician and the nurse side, and could we not have them on together? This was very cutting edge when they did it. Let me show you something else that's stunning. All right, most important. So compare to AAEM, this particular year's database, 284 patients. Texas Harris Health had 328. Look at what they staffed it with in terms of providers. Oh my gosh. And this is a trend, I have to tell you, that I have seen over and over. The most efficient departments are often the leanest. You know what I mean? They can do it with less providers because it works so well. The tendency is when your ER is struggling and failing, you want to throw more staff at it and cry out for more rooms, right? I need more rooms, I need more staff. When in fact, what you really need is better operations. And when we clean it up, we can do more with less. So I thought that's one thing I wanted to point out to you about them. And then take a look at this. And by the way, this was from a different year. You can see the patients per day was slightly different. But door to doc, 17 minutes without physician and triage. Just patients flying through those chutes. And I have never seen anything like it. I mean, patient shows up, is in one of those chutes, and a nurse is out there at the blink of an eye doing a very quick intake, and then taking off, they go to a room. I mean, it's really, really very, very remarkable. So also pay attention. Length of stay, discharge under 3 hours. Length of stay overall under 3 hours. And look at the walkaways. That's left before treatment complete. Don't you think that's amazing? So if you ever have a chance, it's a great place to go sightseeing. I kid you not, you will. And oh, by the way, the lobby looks like a hotel. The lobby looks like this lobby. And I've just never seen a health facility like this. All right, another way we flex, every area should have the appropriate amount of nurses. And from my point of view, it should look something like this. In your trauma room, in your critical care rooms, 2 to 1, maybe even times 1 to 1, depending on what's going on. Main ED, 3 to 1. Mid-track, 6 to 1. If you're doing a mid-track right without IVs, without a lot of IV medications, you can run it that lean. Your fast track, on the other hand, you may have to staff up a little higher. Why? Because it's so procedural. And oh, by the way, tech-heavy places in the ED, you really need a lot of procedural areas, pediatric areas. Why? Why do we need more techs in a peds ED? Holding the kiddies. Yeah, that's it. Holding them down. Exactly. And you don't always think of that the adult is going to go, yeah, put my IV in. What's the kid going to do? What? Screaming and kicking and so forth. All right, you saw this ER yesterday. This is Helen DeVos, pediatric ED. By the way, straight pediatric EDs have a completely different arrival curve. Remember, you've seen the arrival curve for the main ER. I think that's fascinating, and I'm just starting to recognize this the last couple of years. And I'll show you every pediatric ER that I've worked with. I've seen this curve, and what I think it mirrors is the frustration and anxiety of the parents as this kid is unwell and the day progresses. And finally, 8 o'clock at night, they can't take it anymore. They come and seek our help. So they had that rapid assessment zone. You remember me telling you this, and it's what I said for those of you who maybe didn't catch this yesterday. The shift flexes. It can be 4 hours, 8 hours, 12 hours. They decide, doctors and nurses decide at every point whether it should stay open or closed depending on volume. And then these are objective parameters sent. Showing you here, Helen DeVos, door to doc, 11 minutes for a 50,000 visit pediatric ER. That's just great. Look at their walkaways. Look at their walkaways. So planning for high flow. You should have a definition of what high flow is for your department. When are we getting to a break point? And you can do it for the overall department. You can do it for each zone. What does it mean? What do we say? We're crying uncle, help, we need help. So it could be one that just people seem to pick for some reason. When I worked with the ERs, they like this. More than 6 in the waiting room, greater than 30 minutes to see the doctor. Maybe you say, all beds full in this area. That's my trigger for high flow. I don't care what you decide. On the other hand, another ER that said, when there's more than an hour in the waiting room and more than 40 in the ER, I said, could you be a little more ambitious? A little more ambitious to when you're going to jump in and try to fix things. All right, here's a success story that kind of puts it all together. This is Hasbro Children's Hospital, and they called it E squared. It was Excel to Excellence or something like that. I don't know, I can't remember. It had a funny name. That was their name. By the way, an improvement project should have a name and or a slogan, and I'm a big fan of T-shirts and cake. I think you can't go wrong with T-shirts and cake when people are struggling with a change in the department and you launch a project. All right, so there are also 52,000 visits, 36-bed ED. That translates into 142 patients per day. And they did something that it's going to sound great to you at first, but then I'm going to explain to you why it wasn't great. The dermatology clinic was right below the ED. So after 5 o'clock, they put this little sign up. See that? Emergency department, C-pod, after hours, lower level. And there was like no one there to guide patients or anything. They were just like, go down to C-pod. And the poor little mothers and kids had no idea. They had to take an elevator and go down to a dermatology clinic. It looked like this. So now all of a sudden at night, they got another dozen rooms. And they're like, yeah, that's it. And you see, remember, they're crescendoing their volumes at night. Why it didn't work well? Imaging upstairs. Do you image kids? You do a lot of imaging with pediatrics, right? They have a very high rate of imaging. Everything that they needed was upstairs. The extra people to hold the kids down, like we're talking about, upstairs. So everything was now taking much longer. It was a longer proposition. And oh, by the way, the elevators were slow. Anybody find, why is vertical transport in hospitals so awful? Well, actually, we could say that for hotels too, right? It's just a slow train up and down. So that was their process when we started the project. When we started the project, the waiting room every night was just full of sick and crying kids, anxious mothers. There were very long waits to see the doctor, and there were 4% walkaways. What do you think about 4% walkaways for kids? I will tell you, I think it's hard to get it that high. You have to really be doing a lot to have it be that high. And what I found is they were also being pretty snarky and rude with the anxious mothers. Because remember, who's the least likely to walk away from an ED because they're tired of waiting? A mother with a sick kid. They'll stay here because they want you to help their child. So I said, you guys, you're doing great work. I want us to know all your tactics to get it that high. Anyway, this is that curve I showed you, paralleling the anxiety, frustration, and stress of the mother during the day with a sick child. She finally comes to the ER, and so they're busiest late at night. So what they decided to do, re-engineer the flow model, okay, abbreviate intake. They had a long nurse triage process, separate out, doing some patient segmentation. Now that has not been a natural thing in a pediatric ED. To have some segmentation where we put low and middle sick, and then we put really sicker kids. Basically, you can do it this easy. You don't even need ESI. Who needs to lay down? Who can sit up? That simple. Close the basement door. They were aghast when I said, guys, I want you to close the elevators, close the door to the basement. It's not working for you. I know you think you love those extra rooms downstairs. And then we had them plan for high flow. So this is, they've built a lot of flex into their system with this. So now they were doing a split flow model. Basically, they had 2 pods for sick kids that needed to lay down. These are kids that are going to need procedures, whatnot. And then they had an area where their goal for their minor care, their rapid treatment unit, they called it a RAS actually, they wanted those kids turned in 45 minutes. Lofty goal, pretty cool, pretty ambitious, I like it. And they had a flow for what happens on a regular day, and it was a much quicker process, basically quick look triage, go back, see the docs, get your registration, have a nurse see you, then get all of your orders implemented, and maybe you're off to x-ray. So that's our low flow. With their high flow, there was a difference in that they might be seen in an area and then go to a results waiting room or an internal waiting room. And they actually had a nice little space that they made for waiting for tests to come back. So they changed the flow. This is the regular flow. Now this is what we're going to do in high flow. They did close that basement tour. And I'll tell you what, the first day was high anxiety. Mike, I thought they were going to kill us, didn't you? When we said, you are not going downstairs. Well, at one point I felt like I'm going to have to stand in front of the elevator and go, no, we're not going downstairs. We're not going down. And then this little area, somebody had an interesting idea. This is the weirdest looking front end I've ever seen. By the way, that chair over there is literally supposed to be for pediatric dentistry, but okay, somebody had an idea. Ambulances arrive right at where that is. And they had these two little workspaces, and they made this be their kind of rapid treatment unit. They would see the patients, process them, they could go to the waiting room. So they didn't own this. They were only there as long as they needed to be evaluated. If the provider thought they were too sick and they needed a bed, they went to the A and B zones. So they did all this. And this is just showing you their baseline performance. 45 minutes is a long time for a mother with a sick kid to wait to see a doctor. That's a very long time. Those minutes go by slow. Anybody spent time in an ED with a sick kid? Anybody? Right? Am I right about this? That is long. That is years. That feels like years, yeah. And look, their length of stay and so forth was long. Remember, going down to the basement, you waited even longer. Those patients got skipped over and waited 52 minutes. And there I showed you that walk-away rate of 4% based on the national average. Remember me saying it takes a lot to get a mother to walk away. If you look at all of the EDBA peds, 1.6% walk away. It's hard to get them to walk away. You've got more than double there. All right, so then when they used the C-pod downstairs versus the whole change package with the RTU that I just described to you, which built Flex into their system, door to doc for the middle and low acuity, 15 minutes now. They got their low acuity patients in and out in just over an hour. And they processed more patients. So get this, they had more rooms in the old model, more rooms, but they couldn't even see 13% of the volume doing that model. Now with this new expedited model and changing and adapting with a high flow method, they were seeing 20% of their patients there. So don't you think that's pretty astonishing? And anybody see these, use these? This is Tableau. And I love the temperature gauge because it's so visual. So up there is showing you what their door-to-doc was in the old model before we started the project. And see, the red is, I think they set it at more than an hour. Look at how gnarly it got in the evenings when you would go to that ER. Then take a look. Now, it's still stressed a little bit, but remember the arrival curve for them. But look at, they're in the green, which was a less than 30-minute wait to see the doctor. That's their temperature gauge after they implemented all those things. So I love that. Great success story, great note to end on. And then cohorting admissions, we've talked about that, what that could look like as a tactic. Admission holding area, what that could look like. This really is a hospital that I've worked with where they're going to put their admission holds. Not the nicest space, but hey, necessity, mother of invention. They're going to do this. They're doing it right now to see how it'll go. And you've seen that glorious one. Behavioral health protocols, as I mentioned to you, all of these things should happen almost on autopilot. And if anyone wants some of these, I have some if you would like to see what's been done elsewhere. And then transition center, my last cool idea for you. With less than 2 minutes to go, I'm going to make it. What about if anybody that is going to vacate their bed, and you could do it for inpatient as well as ED. Let's say they're waiting for transport of any sort. What if they went to a place that was staffed with paramedics? Doesn't that seem like a natural fit? Could you convince your hospital to do that? And use it for both inpatient and ED patients. So this has actually been done, and I've got an article about it. This was done in Las Vegas with high success, and it's a paper. So could you have a space like this for people, they're on their way home, and we're just waiting for transportation, and we'll call it a transition unit, and it can serve both populations. This is actually an ED that's using this for their transition unit.